Hi guys, this is Dr. Pratheep. Welcome to my channel Pediatrics for Class Bunkers. Today we are going to discuss an important topic, Henoch Schönlein Purpura, which is also known as HSP, and updated terminology for this is IgA vasculitis. So what will happen here is there is deposition of IgA in the small vessel. Because of deposition of IgA, there is formation of immune complexes that causes inflammation of the vessel wall. We call it as vasculitis. Whenever there is inflammation of the vessel wall, there is leakage of the blood that causes palpable purpura. So you can see in the image, there is palpable purpura. So we are going to definition. IgA vasculitis is an immune complex mediated small vessel vasculitis of the childhood. So it can involve any pediatric age group and is the most common vasculitis that is affecting pediatric population. So we are going for criteria. So there is one mandatory criteria and remaining 1 out of 4 minor criteria should be satisfied. Okay, so in mandatory criteria there is palpable purpura should be there. One important thing here is not relating to thrombocytopenia. That's how you have to remember, palpable purpura without thrombocytopenia. Why there is no thrombocytopenia? Generally when there are purpura, that is because of decreased number of platelets that will cause bleeding and it manifests as purpura. But here platelets are absolutely normal and the main problem is in the vessel. So because of vasculitis there is purpura, but not because of thrombocytopenia. So whenever patient comes to with purpura and platelet count is normal, you should think of HSP first. This is the mandatory criteria. Next, 1 out of 4 following criteria should be satisfied. First is because of vasculitis of abdominal vessels, abdominal small vessels, there is diffuse colicky abdominal pain will be there. Patient will come in very severe pain. Sometimes it may be mistaken for any appendicitis or peritonitis and we may open the abdomen. There will be very severe pain. Next, there is deposition of IgA in the joints that will cause arthritis. And third is most important, we are worried about this is renal involvement. So if there is involvement of kidney, it can be either nephritic syndrome or nephrotic syndrome. Whenever there is nephritis or nephrotic syndrome, there should be hematuria. So when you call it hematuria, when there is more than 5 RBC per high power field microscope, we call it as hematuria. In nephrotic syndrome, there should be proteinuria. How you will check for proteinuria? Generally in wards, we'll do dipstick test. On dipstick test, when there is 2 or more than 2 proteins are present, we call it as proteinuria. Or if you want to do 24-hour urine, there should be more than 0.3 grams. So it is 10 times of normal. Normal is 0.03 grams for 24 hours. But here there is 10 times more, 0.3 grams for 24 hours is proteinuria. So renal involvement will be there. Along with that, if you see histopathology, you can see IgA deposits. Generally where you can see IgA deposits, main involved organs are, say, one is skin, second is kidney. So in skin what will happen? There is deposition of IgA, and because of deposition of IgA, there is immune complex formation along with leukocytoclastic vasculitis. What is this leukocytoclastic vasculitis? Whenever there is inflammation, there is neutrophils. Okay, neutrophils will come in that area, and neutrophils release certain enzymes in inflammation. Because of excessive enzymes here, there is digestion of neutrophil by itself that will cause fragmentation of neutrophils. Those neutrophil fragments are called leukocytoclast. So because of leukocytoclast formation, we call it as leukocytoclastic vasculitis. Very, very important for you. Leukocytoclastic vasculitis with IgA deposits. And in kidney, because of IgA deposits in mesangium, there is excessive proliferation of mesangium that causes mesangial-proliferative glomerulonephritis. These things you have to remember. So revising the criteria, first is mandatory palpable purpura that is not relating to thrombocytopenia, and 1 out of the 4 criteria should be there. First is pain abdomen, second is joint involvement, and third is renal involvement either in the form of nephritis, hematuria, or nephrotic syndrome, proteinuria with 2+ on dipstick. If you do histopathology, you can see in the skin there is deposition of IgA along with leukocytoclastic vasculitis. In kidney there is deposition of IgA with mesangial-proliferative glomerulonephritis. Next, going to next. So whatever we discussed, we can see here. Typical rash of HSP involves palpable purpura distributed predominantly over dependent parts, mainly in the body, first lower extremities and buttocks, usually sparing of the trunk. This is an important finding. Sparing of the trunk in HSP. And arthralgia and arthritis that involve almost 80% of the children, and GIT also can involve. Generally they come with painful abdomen, gastritis, duodenitis, whatever is there, but in severe cases there is severe bleeding that will cause occult blood loss. So stool is positive for occult blood and sometimes can be intussusception. We are going to nephritis in the form of nephritic or nephrotic syndrome. That means hematuria or proteinuria can be there. Nephritis involves mostly in first 6 months, very rarely in between 6 months to 1 year. Okay, nephritis will never happen after 1 year. Within 1 year it should be there, and most patients will be experiencing in less than 6 months. Okay. Next, coming to risk factor for IgA nephritis. All patients won't be having IgA nephritis, but IgA nephritis is our main concern because remaining all purpura will subside, pain abdomen will subside, joint pains will subside, but IgA nephritis in 5% of the patients it will cause chronic kidney disease. So we are worried about this and we want to know what's the risk factor for IgA nephritis. So first risk factor is whenever age of the child is more than 7 years. That's an important risk factors. That means elderly child are at more risk of developing nephritis, and prolonged rash for 4 weeks. 4 weeks is 1 month. So whenever there is 1 month of rash, there is increased chance, and severe GI symptoms in the form of intussusception or occult bleed, whatever we discussed, and low factor 13 deficiency. What will happen in low factor 13 deficiency? Factor 13 is fibrin stabilizing factor. So whenever there is fibrin monomers, factor 13 will cross link them and it will seal the blood vessel. So whenever there is already less factor deficiency along with vasculitis, there is more leakage of the blood and more chance of severe HSP, that is leading to IgA nephritis. Okay, this table is only for PG students. Okay, so you want to know the severity of IgA nephritis. The severity is mild, moderate and severe. In mild severity of IgA nephritis, there is normal GFR with mild to moderate proteinuria. That means proteinuria can be either +1 or +2 with normal GFR. But in moderate and severe, there is impaired GFR along with persistent proteinuria. So what is persistent proteinuria? Whenever urine protein creatinine ratio is more than 250 for 4 weeks. This is one important you have to remember. Urine protein creatinine ratio normal is less than 30. Okay, so but when there is more than 250 urine protein creatinine ratio that lasting for 1 month, that we call it as persistent proteinuria. Okay, so in moderate and severe, there is persistent proteinuria and there is impaired GFR, but the thing that decides moderate to severe is crescents. So whenever there is glomeruli are damaged, because of inflammation, there is crescent formation in microscopy. So if less than 50% of glomeruli are forming crescents, that is moderate severity. More than 50% of glomeruli are forming crescent, that is severe. So roughly in mild, there is normal GFR with mild to moderate proteinuria. In moderate and severe, there is persistent proteinuria with impaired GFR. What is persistent proteinuria? There is urine protein creatinine ratio more than 250 for 4 weeks. In moderate, on biopsy, you can see less than 50% of glomerular crescents are formed. In severe variety, there is more than 50% of crescents are formed in renal biopsy. There is other variation called atypical IgA vasculitis. So same as HSP, but only difference is there is hemorrhagic bullae and vesicles in place of palpable purpura. Because of hemorrhagic bullae and vesicles, don't think it will be having bad prognosis. It will be having same prognosis as normal HSP. Okay, but we call it as atypical because lesions are not typical. Hemorrhagic bullae and vesicles are there. This is an extra edge for you. Next, a diagnosis. How you will diagnose HSP? You can see clearly, palpable, how patient comes to you. Patient comes to you with severe joint pains, unable to walk, and he will come with severe pain abdomen. And seeing the patient, you can see palpable purpura. You will obviously diagnose as HSP. So there is a 100% clinical diagnosis. And if you want to do skin biopsy, what you will see in skin, we already discussed. There is deposition of IgA in the skin along with leukocytoclastic vasculitis. But generally skin biopsy is not recommended. So when skin biopsy is recommended, whenever you can see atypical skin lesions, as we discussed above. And one more thing is, whenever there is extensive involvement of trunks and upper limbs. That means we are doubting that it may not be HSP, it may be some other thing, because HSP generally spares trunk and upper limbs are less involved. But whenever there is atypical lesions and it is involving trunk and upper limbs, that means we are doubting other diagnosis like SLE or ANCA associated vasculitis. So you want to do biopsy to rule out the other things. So that's why you have to do skin biopsy there to rule out other vasculitis. In addition, every patient of IgA vasculitis should be screened for kidney involvement, because our main concern is kidney. 5% of the child are going to CKD. That means from 100, 5 children are landing in CKD. That's why you have to measure every time blood pressure and every time urine routine microscopy you have to do for 1 month at least. First 4 weeks, daily you have to do urine routine microscopy along with BP check for first 1 month. Okay. Next we are going to treatment. First, treatment for palpable purpura and arthritis. Nothing to do. HSP is itself self-limiting condition, so give supportive treatment. Arthritis, you all know, you will give NSAIDs for arthritis, but before giving NSAIDs you have to check renal function test. If normal renal function tests are there, you can give NSAIDs, because HSP involves kidney. And in mild to moderate cases, like if symptoms are bearable, mild disease is there, that you can use steroids 1 mg per kg per day, and you will taper over 2 to 3 weeks slowly. But in severe diseases, what is severe disease? Whenever disease is involving brain, pulmonary vasculature and GI vasculature, that is considered as severe disease. We need to give higher dose of steroid. We are going to for IV pulse therapy of methylprednisolone. What is this pulse therapy? Generally we will give 10 to 30 mg per kg per day steroid IV over 5 days. After that again we are shifting to oral steroids and we are tapering over 4 weeks as usual. Next, in organ threatening or life threatening condition, we can go for IVIG or plasma exchange. What is IVIG? Intravenous immunoglobulin or plasma exchange you will do in life threatening conditions. And one important thing is, anything you want to do for hemorrhagic bullae, nothing to do, you just wait, whatever you are doing is enough, it will subside by itself. There is no specific treatments for hemorrhagic bullae. Even the same steroid dose we are giving, oral steroids 1 mg per kg per day is enough for the hemorrhagic bullae also. We will clinically evaluate the child with IgA nephritis. First, week 1 to week 4, whatever we are discussing is week 1 to week 4, what you are sending already, urine routine microscopy, and you are checking the BP daily. Patient is good, want to discharge the patient. So for next 2 months, 2 months is 5 weeks to 12 weeks. So for 5 weeks to 12 weeks, every 14 days you ask the patient to come and do urine routine microscopy and BP check. If everything is good, just follow up the patient monthly once till 1 year of age, because HSP nephritis can develop up to 1 year. So till 1 year you follow up the patient. So if nothing is there, nothing, no abnormality, done. But during this course, anytime you feel there is symptoms of nephritis or urine RM or hypertension that is showing towards nephritis, then you have to evaluate. Generally, we will send the patient to nephrologist, and if they indicated, they will do kidney biopsy. Based on that, they may decide. Generally, if mild cases, they will decide oral prednisolone. In moderate to severe cases, they may start immunosuppressive agents like azathioprine, mycophenolate mofetil, and cyclophosphamide can be used. So we will revise HSP once more. HSP definition by itself, IgA vasculitis, because of HSP is an immune complex mediated small vessel vasculitis of the childhood involving all pediatric age groups. How it presents? It presents as palpable purpura, pain abdomen, joint pains, and there can be renal involvement. So mandatory criteria is palpable purpura not relating to thrombocytopenia, and remaining 1 out of 4 criteria should be satisfied, that is pain abdomen and arthritis, renal involvement and histopathology. Renal involvement can be either in the form of nephritis or nephrotic syndrome. In nephritis, there is hematuria more than 5 RBC per high power field, and in nephrotic syndrome, there is proteinuria more than 2 plus on dipstick, or per day it is 10 times 0.3 gram per 24 hours. And if you do histopathologically, you can see in skin biopsy there is deposition of IgA along with leukocytoclastic vasculitis, and in kidney there is IgA deposits with mesangial-proliferative glomerulonephritis. Next, HSP can involve dependent parts, lower limbs and buttocks with sparing of trunk. And almost 80% of the childs will be having arthralgia, and 50 to 70% patients will be having GIT involvement in the form of gastritis and duodenitis. In severe cases, there may be GI bleeding or intussusception. For that, you have to operate. And incidence of nephritis is 20 to 80%, and less than 5% of cases will go to CKD. Incidence of nephritis will happen mostly in first 6 months. So most common presentation is hematuria. That means most common is nephritic syndrome compared to nephritic syndrome. Risk factors for developing IgA nephritis is age more than 7 years and rash lasting for 4 weeks, and there is severe GI symptoms and low factor 13 activity. And a typical IgA vasculitis is same everything except hemorrhagic bull and vesicles. Management is same. It bears the same prognosis. Generally, skin diagnosis is completely clinical. Skin biopsy is indicated whenever there is atypical lesions or extensive lesions involving trunk and upper limbs to rule out other vasculitis such as ANCA and SLE vasculitis. And you have to measure all the children urine routine microscopy and hypertension to rule out any kidney disease. So in treatment for purpura and arthritis, just supportive treatment. For the involvement of GIT remaining organs, in mild to moderate cases, you will give oral steroids with 1 mg per kg per day with gradual tapering. And in severe cases, start with IV pulse therapy of methylprednisolone 10 to 30 mg per kg per day for 4-5 days, then followed by same 1 mg per kg per day steroid with tapering. Whenever there is organ or life-threatening involvement, we will go for IVIG or plasma exchange. And in hemorrhagic bull, nothing to do. Even the same steroid dose, everything works for it. Whenever you are coming to evaluation, first 4 weeks, you will send urine routine microscope and BP daily. If child is normal, then you ask the child to come for 5 to 12 weeks. That is next to 2 months. Next to 2 months, you ask the child to come every 14 days to do same urine routine microscopy and BP. If nothing is there, ask the patient to come monthly once for 6 to 12 months, because 12 months there is risk of nephritis. After that, no need to come. Child is absolutely alright. But if there is any evidence of nephritis in between, we will refer the child to nephrologist. He will evaluate everything and he will decide treatment, either oral prednisolone or IV pulse therapy, or he may keep on immunosuppressive agents if not responding, like azathioprine, mycophenolate, mofetil. Okay, thank you.